Hello, my name is Rosetta Oliver. I am a clinical nurse leader, graduate student at Rowan University. My capstone project is Staffing by Acuity to Improve Outcomes. My objectives are identify the various staffing models, identify the disadvantages of the traditional staffing methods, list the advantages of using an Acuity staffing tool, list factors that are included in the development of an Acuity staffing tool, and list the disadvantages of an Acuity staffing tool. Pavilion 6 is the microsystem that I chose to use for my capstone project, and my goal was to develop an Acuity tool that was for that could be used by Pavilion 6. Pavilion 6 is a 30-bed post-operative surgical unit that has post-operative bariatric patients, colorectal surgical patients that usually have extensive bowel surgery, GU patients. These include patients that have had bladder surgery or TURP, and also surgical oncology patients that are usually post-Whipple. Pavilion 6 has various levels of care, telemetry monitoring, intermediate surgical care unit, which is called the ICU. These patients require every 2-hour nursing care and documentation. They have continuous pulse ox. They may have arterial lines, central lines, many drains, and multiple medication administrations. Pavilion 6 can benefit from using an Acuity tool due to the complexity of their patient population. Like I mentioned previously, the microsystem is Pavilion 6, a 30-bed post-operative surgical unit with various levels of care. An assessment of the microsystem was done using the 5 Ps. The purpose was to improve patient safety and outcomes by using an Acuity tool for staffing. The patients, like I said previously, were your post-op surgical oncology patients, bariatric patients, post-operative GU patients, and colorectal surgical patients. The process is you usually get patients come in pre-admission. They get bed assignment according to the bed request that's in Epic, which is our electronic health record, and it's usually not based on Acuity. It's usually based on using the staffing grid according to the number of patients. The professionals that are involved in this microsystem: RNs, your critical care techs, unit secretaries, APNs, the pharmacists, physicians, social work, and home care coordinator. The patterns, you have your staffing ratios, which are usually 5-to-1 or 6-to-1 in a telemetry assignment, or 3-to-1 or 4-to-1 in an intermediate assignment. The performance are usually through HCAP scores, daily leadership rounds, staff satisfaction measured by staff engagement scores, and using an Acuity tool can result in decreased cost by decreasing the length of stay, and also improving the nurse sensitive indicators. There are different staffing models. First, you have your HPPD, which is hours per patient days, and this is staffing according to the daily census. Also, you can staff by ratio, which is based on number of patients assigned to a nurse. And then you have the Acuity, which is workload is according to the patient's needs and complexity of the patient care. Nursing units were staffed according to midnight census in the past. There are problems that you may have with staffing the traditional method. These may include, does not include different levels of patient care. It does not include acuity level of patient or complexity of the patient. And the HPPD staffing is based on cost and average daily census. At the present time, this is what Pavilion 6 is staffed by according to HPPD. There are many benefits of using a Acuity tool to staff by. and it decreases costs. It also decreases length of stay, as I mentioned before, improves nurse satisfaction, and also improves patient satisfaction. It provides quality patient care, improves outcomes. For example, like I mentioned previously, also nurse-sensitive indicators such as your Claudies, your Clabsies, pressure ulcers, and falls. Research suggests there is a direct correlation between nursing staffing and nurse-sensitive outcomes. Uh, Things that you need to take into consideration when creating a Acuity staffing tool. First of all, the physical layout. And this could be a problem or issue for Pavilion 6 because Pavilion 6 is in the new building and it's single patient rooms and the length of the hallways are really long. So if you're using Acuity and patients and room numbers, you might have to crisscross sometimes to the hallway. But the good thing with Pavilion 6, their ICU patients are usually in the back way of the hallway, so they might go from rooms 22 to 31. So any of those patients in those rooms are usually considered ICU patients, so you're able to group your nurse in that specific area. You need to also consider workflow, also the available support staff. You may have it might make a difference because you may have a critical care tech, or you may have a nurse associate. So if you have a nurse associate, they're not going to be able to do your critical skills, such as, your technical skills, such as blood drawing and EKGs. And also you must consider the complexity of the tasks and procedures. And also you need to consider the educational and the emotional needs of the patients. And also you need to consider and you might include family members into that too, because this could take up a lot of the nurse's time. As a clinical nurse leader, you're going to assist the staff in the development of an Acuity tool. So you might want to consider some questions, and this might be find out what tool, if any, they are using presently, what type of tool will work for their unit, what does an ideal tool look like, and how would you develop an Acuity tool for your unit Pavilion 6. As a clinical nurse leader, you would also assist the team in the development of an Acuity tool. You will act as the team leader, provide the staff with different types of Acuity tools, and then they can customize it to their unit. You can discuss the importance of utilizing an Acuity tool, which is to promote quality and safe patient care. Research also has shown that using an Acuity tool has reduced medication errors. This next slide is an example of an Acuity tool that was developed for Pavilion 6 with the assistance of the leadership team. It was customized for Pavilion 6 using tools, Acuity tools from different area hospitals, for example, Temple University and Spira, Woodbury. The leadership decided that they preferred the green, yellow, and the red. Green means that the patient could probably be in a 6-to-1 ratio. Yellow, they need to be in a 5-to-1, and then red, definitely a 3-to-1 or a 4-to-1 ratio, depending on what other things they have. These are some of the tasks and some of the care that is required by the patients, that are needed by the patients that are on Pavilion 6. There are some disadvantages of using a Acuity tool, and they are the forms can become redundant, and the nurses feel like they are unnecessary. Sometimes patient care is not predictable on the using the forms. The patients might be more complex and require more time than what the form seems to present. And it also takes time to complete the forms, and a lot of times the nurses do not have the time to do these forms. And some nurses may feel like they're not using their professional skills or judgment. And then I did look at other Acuity tools from other other area hospitals, and some of them use checks against the task that needs to be done, and they tally those checks up, and it goes from a acuity scale of 1 being less complex to 4, which means that a complex patient requires more acuity. So the total, the more checks you had, the more difficult this patient might have been to take care, or more time that's required for the nurse to take care of this patient. Also, I also noticed that if you have an electronic medical health record, and nurses have to document in the flow sheets, what they do, their nursing care. So there should be a way that you can link the electronic health record with the nursing task, and then maybe create a Acuity tool using that. But it would have to be customized for every unit, so that might be a little difficult because everybody have different levels of care of patients. In summary, research has shown that an Acuity tool can be used to reduce hospital costs and improve outcomes. I would like to thank you all for listening to my presentation. I would like to say happy holidays to all. I would like to say a special thank you to Dr. O'Neill. I would like to give you a special thank you for guiding me through this journey for the last year and a half. Thank you so much. I wish you well. I would also like to say thank you to my preceptors, Linda Wicker, Clinical Educator at Cooper University Hospital, and Lynette Jones, Clinical Director, Pavilion 6 at Cooper Hospital. Thank you all for your expertise. Enjoy the holidays.